Good morning, everybody. This is the last lecture before lunch, and it is my pleasure to introduce your president right now, Kevin. I've known this man for 20 years, and he has been a colleague. He was one of my PA students the very first year I was at the school. We served in Afghanistan together, and for the last 6 years, I think, we've been on the board of directors. Kevin is originally from Burlington, Ontario. He joined the Armed Forces back in 1995. He spent 14 years as a medical technician before he became a PA in 2011. He practiced primary medicine in Ottawa for 4 years until he was transferred to Fredericton, New Brunswick, where he retired from the Canadian Forces in 2015. He's been working at the Dr. Everett Chalmers in Fredericton in the emergency department ever since. His wife, Kelly, and him are raising 2 sons in New Brunswick. And in addition to his physician assistant degree, Kevin also has an undergraduate degree in geography from McMaster and has completed his master's in physician assistant studies from the University of Nebraska. Kevin.
Thank you very much. We're slightly early, but I think with the crowd here, everybody's ready to start thinking about lunch. I thought I'd take a second and sort of figure out how this works. It worked a minute ago.
It happens to people that,
I'm sorry.
it also breaks down.
Okay.
Every 90% connected.
Okay. Oh, can I have the next slide, please? This will be my signal for that. So I thought I'd explain a little bit why I picked this class, this lecture. First of all, I'm sure you'll appreciate I'm sympathetic. You've heard a lot of me talking already, so a little cruel of me to inflict another lecture on you. Ryan Bennett is my colleague at the Chalmers. Is Ryan here? He's coming, that's fine. Why I decided to offer this as a lecture is over about 6 to 9 months last year, Ryan and I saw, I don't know, like 8 cases of exertional rhabdo and developed a comfort level. We shared stories back and forth. I think Ryan owns the high score. He had a patient with a creatinine kinase of over 200,000. So we'll just give him a little congratulations, Ryan. But I offer that as an appreciation that a lot of what I'm sharing here today is some of his experience as well. He was kind enough to proofread these slides, so I appreciate that. By all means, I'm not an expert in exertional rhabdo. I just happened to see a lot of it in a very short time, and I found it interesting. And so that was sort of my motivation for offering this class. While I was doing the research to prepare for this, I came across a clinical practice guidelines from the US military that was published in 2021. And you'll see that referenced. And I think of the different things I read, if you were to leave this and say, I wonder why Kevin didn't talk about this. What did he mean by that? Look at that guideline. It was excellent resource. And I've included that in the reference for you. I know there's other types of rhabdomyolysis, so, certainly medication-induced positional rhabdo, and some of the treatment overlaps, but the focus of this talk is going to be exertional rhabdomyolysis. So can I have the next slide, please? These are the just general topics that we're going to cover, define what it is, what it looks like, what we should do first, who gets admitted, and complications of the rhabdo and the treatment itself. And while I did the reading, I had a chance to sort of learn a little bit more about next steps for exertional rhabdo. Is it just stop PT for a little bit, don't work out so hard, this is your fault? Or, I learned a little bit about underlying conditions that might predispose people. So we'll touch on that a little bit, but that's actually a huge topic. And you'll get a sense of that from my slides, that there's a lot to learn there. Can I have the next slide, please? So exertional myolysis or rhabdomyolysis is skeletal muscle breakdown with clinical and laboratory findings. The definitions vary. Some experts propose a creatinine kinase of greater than 10 times the upper normal limits. But really the consensus is that you should consider exertional rhabdomyolysis as a diagnosis at 5 times the upper normal limits. I think practically you're not going to see a lot of symptoms when the CK is 1,000, okay? But does that mean you should ignore that patient? It's probably a patient that you should consider tracking and repeating it, because the CK, the creatinine kinase, can peak. If you know, it's not going to peak till about 48 to 72 hours after sort of that exertional insult to the system, if you will. And you know, to be exertional rhabdo, there should be a combination of laboratory findings and muscular discomfort in the setting of recent exercise. And I think that's another thing I wanted to pause is, you know, when I started, you know, my training about exertional rhabdo, I had a real sense that it was this kind of diffuse muscle ache, and it was very painful, and that should be my trigger. And I have seen patients with diffuse myalgia or lower body myalgia after an intense spin cycle. But I have seen 2 or 3 patients with unilateral limb myalgia. And that was, I mean, I think that's one of my takeaways. I don't think early on that I really appreciated that that could be exertional rhabdomyolysis. I think, you know, nobody likes, probably the first case I saw that I missed was an 18-year-old girl who'd taken a job landscaping and presented with right leg discomfort after a long day's work. And I mean, I sent her home. It sounded like a hamstring strain. She didn't have any urine findings. She didn't tell me about any. She didn't have a fever. She wasn't hyperthermic. She hadn't fallen. It wasn't a blood clot. I did a D-dimer and I sent her home. And she represented with more diffuse symptoms and an upset mother that I hadn't diagnosed this presentation with exertional rhabdomyolysis. Yeah. All right. So, you know, that just as a, you know, add that to your differential for unilateral, you know, in this case, so her CK was actually quite mild, but in the end, that was the diagnosis. So just be a little bit vigilant of the different ways that myalgia can present. Can I have the next slide, please? So at a muscular level, prolonged, repetitive muscular overload overwhelms the aerobic mechanisms, leading to anaerobic glycolysis. Okay, this leads to death at the myocyte level, and tissue causes metabolic acidosis. The kidneys become flooded with acidotic tissue, and you end up with this vicious cycle. Why do we get it? All right. So, you know, the patients I've seen, mostly they've done it to themselves in the gym or in the workplace. In Fredericton, Ryan and I have each seen 2 or 3 patients from a specific spin class business. So the nurses actually wrote from Spinco. Oh, I wonder what that is. All right. Why does that happen? Well, there's some extrinsic factors. Okay, you know, medications can increase muscular stimulation, so amphetamines, cocaine, alcohol, and you add exertion to that, that puts a patient at risk. Okay, dietary supplements, especially those with caffeine and stimulants. Again, this increases sort of the resting state of the muscles, and when you add exercise to that, those patients are at greater risk of developing ER. Extremes of temperature, so humidity, elevation, and temperature. So that's one of the theories about the specific spin. Like, is it simply too hot in that business? Is it simply too warm, as well as, you know, the exertions and the group fitness? And we'll touch a little bit on that in a moment. So leadership has a role. So this, if you remember, I've drawn a lot of this from a military guideline. And, you know, so this is the idea that it's group-led physical fitness, maybe younger soldiers being pushed to do things that they're not ready to do. They're in a group setting where they don't want to slow down or can't. They're not allowed to. It's the military. You'll see one of the references is NCAA guidelines, okay? And this is echoed in their teaching to coaches and personal trainers in the NCAA sports world, okay? To avoid hazing type workouts, punitive type workouts, too much, in early stages of a training camp. So there's a note to leadership, just be a little bit mindful at the extremes of exercise. Allow athletes and soldiers to listen to their own body. I wish I'd known that a few years ago. So intrinsic factors, what characteristics are there about a person that predispose them? So medical conditions such as infection, dehydration, hypo and hyperthermia. Okay. There are genetic, metabolic, and autoimmune disorders. Now, I'm not going to go into that specifically. You're going to see me touch on this at the last few slides, sort of what next. And if you want to learn a little bit more about that, I encourage you to start with the guidelines that I mentioned. Okay. Sickle cell trait, I want to touch on a little bit. Now, working in New Brunswick, I don't have a big experience with sickle cell trait. Okay. Doesn't mean it's impossible. But again, these are drawn from the U.S. military guideline that, recruits from a large different ethnic pool. And what they recognized is that the presence of sickle cell trait with exertional rhabdomyolysis can lead to a very profound circulatory collapse. And so there's significant risk to the patient if there's predisposing sickle cell trait. They're more prone to exertional rhabdo, and the outcomes are more serious. So deconditioned athletes or soldiers are more prone to exertional rhabdo, and also the soldier that wants to do it itself, they're doing it to themselves. So yesterday, Greg told me a story about a soldier on his lunch, went to the weight room and decided to see how many pull-ups he could do in an hour. And it turned out it was a lot. This is whether you want to call that highly motivated or some other intrinsic characteristic is up to you. But they did cause a rhabdo to themselves. Okay. We'll talk a little bit about differentials, if I could have the next slide. So, I touched on unilateral leg pain by all means, DVT, sepsis, septic arthritis, those should all be on your list of differentials. But specifically for exertional rhabdo, we're aware of delayed onset muscular soreness. It usually peaks about 48 hours. So this is myalgia without an elevated creatinine kinase. Okay. No urinary changes. They can have quite a bit of pain, but if they have pain but a normal CK, you can consider the timelines. Should you bring them back in 24 hours to have CK checked again, just to be sure? But really, if it's been 48 hours and the CK is normal and they're sore, I don't know. I mean, I think probably you're dealing a little bit more with DOMS than anything else. Hyperckaemia. So, if you drew a CK at the end of every marathon, you would probably get some pretty staggering numbers. But do they have this myocytic death? Do they have exertional rhabdomyolysis? It's probably more of a lab finding than anything else. Okay. And then, of course, you can have patients that'll present with urinary findings, urinary complaints. They've exerted themselves and they're presenting without a lot of muscular discomfort, but they're having discolored urine, blood in their urine. And so that's frequently joggers hematuria, and should be evaluated in a different, it shouldn't be ignored. Okay. They may warrant a cystoscope or some upper renal imaging, but no CK with blood in the urine. You should consider joggers hematuria, which is a traumatic shake at the sort of microcellular level in the kidneys and leads to blood in the urine. So who should we consider exertional rhabdo? Okay, there should be exertion. Okay, there should be severe muscular pain. I touched on that a little bit. It can be diffuse or isolated. Okay, and or urinary findings. Okay. You should begin by thinking about exertional rhabdomyolysis, collecting a full set of vitals. If the patient is hyperthermic, you're in the wrong lecture, right? Don't forget about exertional rhabdo. Okay, but if they're hypothermic, you need to immediately cool the patient and proceed with aggressive cooling measures, consider a tox screen, that sort of thing. Okay, so if you're going to proceed with just focusing on exertional rhabdomyolysis, they should have a normal temperature. Okay. We've got a few blood work, basic blood tests listed on there that are usually quite obvious. I'm going to highlight a few of them for discussion. The CK is the one we're looking at the most. You'll notice that at the end, there's liver enzymes. Okay. It's possible that you'll see highly elevated liver enzymes in the presence of exertional rhabdomyolysis. Okay. That's often inflammatory. It'll just resolve on its own. Okay. So if you see that and you're thinking, oh, is this a hepatitis? Well, I'm not saying don't think of that. All right. But in the presence of exertion with abnormal liver enzymes, they should be monitored. They should be followed. But it shouldn't shake your primary diagnosis over much that you're pursuing exertional rhabdomyolysis. Okay. Let's see. Can I have the next slide? So you've got this patient that you're concerned about rhabdomyolysis. You get the CK back, it's greater than 5 times the upper normal limit. You should start treatment. We'll talk about it a little bit in a moment. If it's under 5 times the upper normal limit, are you done? Not really. You kind of have to decide where you are in the evolution of things. If it's between 5 and 10, so it's under 5 times the upper normal limit, and he just finished the marathon yesterday, yeah, you probably want to bring that guy back. Okay, check it again. Make sure it didn't climb overnight. And then again, you have to decide about patient reliability, different factors like that. Are they coming back? What's safe for the patient? If the urine is completely clear of red blood cells, we'll touch a little bit of that on a second. Negative urine, you can think about other diagnoses, all right? But again, consider tracking that CK. You'll notice that the initial workup, I don't talk about myoglobin. All right. And that's because we're still sort of in that screening phase. So absolutely a urinalysis is required. In the urinalysis, there'll be a dip that'll be positive for blood, but the microscopy won't show blood. Okay. So that's reacting to myoglobin. Now that's, you still need to, if you want, you can go on and do a myoglobin, right? It's expensive. And maybe not mandatory if the CK is under 10 or 15,000, all right? But it doesn't need to be in your initial workup. But urinalysis and microscopy, pardon my stutter, microscopy, you know what I mean. You'll figure me that way. Early on in your evaluation, you should be thinking about the complications of exertional rhabdomyolysis. So one of them is acute compartment syndrome. And so this is fuddling. Like if you have that patient they have one limb that's giving them trouble, start thinking about compartment syndrome early on. Again, if the CK comes back slightly elevated, you're probably not having an acute compartment syndrome, but it should be something that's watched. If you think that you have acute compartment syndrome, then by all means, reach out to your orthopedic colleague to confirm the diagnosis and talk about further management. As the CK elevates, the risk of kidney failure, AKI, increases. There is some risk of disseminated intravascular coagulation. So if you want to do PT, PTT early on, but again, this goes with untreated, prolonged exertional rhabdo. Okay. The treatment and the condition exertional rhabdomyolysis is associated with electrolyte abnormalities, and many of those can cause cardiac dysrhythmia. So, think about having cardiac monitoring early on, especially if they're quite unwell and at the extremes of management or the extremes of the higher elevated CKs. You have the next slide, please. So the initial treatment should be normal saline, 1 to 2 liters per hour, especially if they're anuric. If they're not passing urine, you need to be very aggressive with your fluid management, okay? You want to get urine output of 200 to 300 mils per hour. You can start with normal saline at the Chalmers as you get internal medicine involved. And I had one rhabdo patient go to the ICU. They always switch them to lactated ringers. I mean, both fluids are isotonic, but I don't really want to go down the rabbit hole too much of normal saline versus lactated ringers. And I think the argument, as you get these higher volumes of fluid, then I think we can all agree that lactated ringers, it's slightly more isotonic than normal saline. And when you're giving liters and liters of it, you do want to kind of maximize benefit. Avoid anti-inflammatories, no Toradol, no ibuprofen. Okay, that's Tylenol, or if they're very uncomfortable, consider low-dose narcotics. Okay, and we already talked about the Foley. Are there any questions about the initial management? So certainly my practice is if I've drawn the CK and I'm thinking this exertional rhabdo, they're getting a liter, okay, while I wait. If it's crossed my mind and I'm waiting, I find my lab, I call it must be bad, they're counting the CK by hand. I have this, it'll be the last lab test that comes back. I'll have everything else and I'll be waiting and waiting for the CK. And if that happens, I give them the second liter. I know they're counting and it's high. All right, Aaron? Because you want to aggressively understand how the flow of urine, okay, so you can track the volume per hour once you get them going again. Yeah. It's not going to start the flow of urine, right? Yeah. They need more monitoring. Yeah. That's right. More than anything else. It's not therapeutic. Good question. Any others? Okay, so let's talk about next steps. We've done the initial treatment. We've got the CK. Maybe they're improving. We've confirmed it's exertional rhabdo. Who are we scared about? Who goes home? Who needs admission? Who needs follow-up? So, low risk patients can go home, but that's hard to understand. Who's low risk? So low risk if the CK is under 20,000, they have good follow-up, they did well, they're not in a lot of pain, you can start thinking about going home, all right? Most of those patients should have a CK drawn in 24 to 48 hours. Okay, let's go to the next slide and we'll focus on who should come into hospital. Okay, so high-risk patients. You should consider them a high-risk patient if they're greater than 20,000. Now, I'm sure Ryan's story, he got pushed back from a hospitalist team with a patient who is well over 100,000. The literature is quite clear. If it's over 20,000, you should consider. And he was able to get admission by involving internal medicine to do some teaching with the hospitalist. So it does happen. People don't always know a lot about rhabdomyolysis and who needs to go home and who needs to stay. If you think there's any chance of compartment syndrome, AKI, they need to come in. If their creatinine is climbing despite your fluid resuscitation, they should come into hospital. Okay. If you confirm myoglobin, so remember I talked about when to order it. So if I see that higher than I expected CK, that's when I order a myoglobin, that urine myoglobin. That's going to help me in my disposition planning. Do they have a metabolic abnormality, or the potassium out of range, high or low? Those are people that obviously they can't go home because of the the electrolyte abnormality. Sickle cell carrier probably shouldn't go home. We talked about that. They're at risk of worse outcomes. And if you worry that they're not coming back, that's someone you can consider holding in hospital for sort of social reasons. I almost skipped this slide. This next slide, it's called inpatient care. I don't do it. I mean, I see you in the emerge, I send you home or I admit you. I really don't know what happens afterwards. The CK should be tracked and trended for about 12 hours, every 12 hours, forgive me. And you should continue aggressive IV fluids in that 250 to 500 mils per hour. Labs should be drawn, probably what that CK you should be doing, extended lights, to make sure that the treatment, the fluid resuscitation isn't causing an electrolyte abnormality. Monitor for complications. I did have, this was my patient that went to the ICU. We decided to resuscitate, continue large volumes for the first 8 hours. And she went on to develop flash pulmonary edema. She had a brief episode of shortness of breath and a worrisome chest x-ray, and that was managed with 1 or 2 doses of Lasix. So that's the sort of thing that can happen, you know, as a sequelae of aggressive treatment. Then you can start thinking about sending them home if that CK is peaked and it's reducing, it's falling, and you've withdrawn IV fluid. They can go home. Right? It's not going to bounce back. So this next slide starts to get into a little bit of newer territory for me, okay? And we'll just get the next slide, please. You know, who gets recurrent exertional rhabdo? Who's predisposed to having it again? Who's at risk? So you should start thinking about a diagnosis or worrisome situation if the story doesn't match. Like, you know, they did a handful of push-ups. Like, how deconditioned was this athlete? Okay, that they got exertional rhabdo, or is there an underlying genetic abnormality, okay, that needs further workup? If they have ongoing CK elevations after 2 weeks. Okay, you followed this patient, you know, they want to know, can they go back to sport, back to activity? It's not falling. I think it gets a little worrisome. Like, they're probably going to end up in trouble again if they go right back to full sport. If there's a family or personal history of exertional rhabdomyolysis, why is that? That bears further investigation. It's kind of an odd diagnosis. Why? Well, my father had this, my brother had this. That's strange. Malignant hyperthermia there's a genetic link with exertional rhabdomyolysis. So if there's a family history of MH, then you consider further workup. We'll talk about that in a minute. And then the sickle cell trait bears more attention. Can I have the next slide, please? So what does the further workup looks like? I didn't list all the labs that they mentioned in the guidelines because mostly I'd never heard of them. Okay, I view them as a little bit beyond the scope as what I would order. But if I did have an athlete who had 2nd or 2 or 3 goes with exertional rhabdo, there really wasn't a real pattern for it, then, you know, are they safe to keep doing this? You probably should have some sort of neurology consultation. And the guideline talks about, you know, a neurologist who specializes in neuromuscular disorders. I doubt I would find that in Fredericton. That would probably be somewhere else in Canada. Maybe in Halifax, I could find that. But depending on your center, that's something to start thinking about. And so we talk in the guidelines, they talk about a set of lab work called an exercise intolerance panel. I encourage you to have a look at that if you're curious. You know, a muscle metabolic panel was something different. And then having a look at the muscle at a biopsy level. Is it normal? And again, that's the sort of thing that's for down the road. So these are the references that I talked about. At the very bottom, Nye is the editor for the clinical practice guideline that I draw your attention to as a great resource if you'd like to read a little bit more about it. I included the NCAA Sports Science Institute, partly because there was that reference was very accessible. It wasn't meant really for medical professionals. It was meant for coaches and trainers. So if you're being asked to provide resources to people in the fitness world, it was accessible. There wasn't a lot of techno garble there. It was what to avoid at a practical level and how to help your athletes through this and avoid rhabdo. So I think that's a worthwhile resource. We'll go to the next slides. And I'll ask if there's any questions. Yes. Yeah.
I imagine it's almost like to some degree that if you pushed harder in that workout, that it could have potentially
is there a patient that, you know, if they come in with a certain set of, you know, I had DOMS for a week, that they're like at risk of rhabdo if they continue on the same path? Like, is there a patient that's with certain symptoms or certain activities or anything like that?
So you have a patient in with 3 or 4 days of myalgia. You've done a CK, it's normal, and you assess them as having DOMS. So you're asking me, you know, what counseling do I have for that patient? You know, I don't think the presence of DOMS over and over again is an individual risk for rhabdomyolysis. I think if your assessment of the patient is that they're pushing too hard in their workouts or being pushed too hard, okay, then perhaps there's some coaching there that, you know, maybe you should take it easy a little bit. I think that recurrent DOMS, you know, that athlete is probably more at risk of developing overuse injuries and tendonitis and things like that. And I don't think it's a specific risk for developing rhabdo. Well, I'm happy to throw that to the floor. Like, you know, does anybody else have any expertise in that area and opinion? Did everybody hear the question? So the question is, does DOMS on its own sort of act as an independent risk for rhabdo? And I haven't heard of that as a warning sign. Yes, sorry. And I'm not aware of that. You know, I think that if you think it's a pattern and that risk, you know, it speaks to the patient personality, maybe they should be counseled to slow down a little bit. Good. Any other questions? Yes, please. Rheumatology? Yeah, I mean, I think that belongs on a differential. I'm not like I think autoimmune disorders often travel in pairs. And so if there's other symptoms, you know, mucosal ulcers, joint swelling, that sort of thing, that would push me a little bit more towards rheumatological disorder. That's a good question. Did everybody hear that? No. So at what point do you consider a rheumatological source? And I think it belongs on your differential at all points, but things that would tip me there is unexplained fever, mucosal ulcers, other symptoms being involved, joint swelling. Yeah. 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 Sure. Interesting. Yeah. Any other questions or stories, comments? Yes, please. Mm-hmm. Right. Right. Yeah, absolutely. Any other questions or comments? I know I'm right before lunch. So with that, thank you very much, everyone, for your interest and attention.